Welcome to the CSI public seminar. We're delighted to bring you this seminar today on the topic that fits in with the 16 days of activism against gender-based violence. So, hi, my name is Kelda from the Centre for Social Impact. I'll be handing over in a minute to the facilitator and the panellists. I'd just like to welcome you here. Also to acknowledge that we are today on Whadjuk land of the Noongar Nation. So just to acknowledge that, you know, this is their land, unceded, but we pay our respects to elders past and present. So yeah, this is the 16 days of activism. It's a global initiative. So we think it was really important for the Centre for Social Impact to be part of this conversation. And I love that it was 16 days because, you know, there is so much to explore on this topic. We're not going to get through, even scratch the surface in an hour, but we just think it's important to keep having conversations because it's so complex. So we actually just, you know, really love the opportunity to be part of this. The dates of the 16 days, it started on the 25th of November and ended on the 10th of December on Human Rights Day. So perhaps people in the audience would have already been participating in this activism. So we invite you to bring your knowledge and insights today as we sort of reflect in this space. So yeah, as I said, the campaign is international. It's about ending violence against women and girls across the world. So family and domestic violence is part of that, but it's also a broader conversation about gender-based violence. The aim is to raise awareness, motivate positive action, and highlight the organisations and communities, such as the people on the panel today, who are actually doing something in this space that's really significant. And yeah, we hope that with raising awareness today, that just adds a tiny bit to make a positive difference for women and girls. So just so you know, when this ends at 2, we'll say goodbye to our online audience, but anyone here today face-to-face, we invite you to stay, hang around for a drink with us, just in the foyer. It's very informal, but we just thought it would be good to just continue the conversation, especially with all this knowledge in the room. So I will now hand over to Dr. Marina Atkins, who is a senior researcher at the Centre for Social Impact and has worked a little bit in this space, and to facilitate from here.
Hello, everyone, and welcome. And thanks, Lisette. And thank you all for joining as we look at this critical issue that continues to plague our society, violence against women and girls. And this is a pervasive problem that transcends geographical boundaries, cultural differences, and socioeconomic statuses. It is not something that is happening on the other side of the world to a culture far away from us. It is happening right here, right now, in our rich country, in our developed country. And it stands as a stark driver of gender inequality, permeating many aspects of our lives, including employment participation and financial security. And it is exacerbated in times of crises, such as financial crises, but also in times of disasters. And as we're reaching this era of more climate uncertainty, the risk of greater violence towards women and girls is increasing. So FDV doesn't only shatter lives, but it is a leading cause of homelessness for both women and children. And its impact is far-reaching. It extends into health, inclusion, and participation. And the burden of family and domestic violence is disproportionately borne by members of our society, such as Aboriginal and Torres Strait Islander people from culturally and linguistically diverse backgrounds, people who identify as LGBTIQ+, and those with disabilities. But there's a real danger in thinking that FDV is something that affects the other, the marginalized groups in our society. And Rosie Batty says, I want to tell people that family violence happens to anybody, no matter how nice your house is, and no matter how intelligent you are. Let's turn to technology. In our rapidly advancing world, technology has become a double-edged sword. While it has brought incredible advances, robots that clean out carpets, and I don't know, are we on our way to Mars? Something like that. It has also provided new avenues for domestic, family, and sexual violence and abuse. It allows perpetrators to control, stalk, and harass their victims using digital tools. Now, this form of abuse not only adds a layer of complexity to an already grave issue, but also requires us to adapt our responses to address the evolving nature of violence. Now, the statistics are harrowing, as can be seen behind me. And the roots are intertwined with societal attitudes that perpetuate these very harmful ways of being. A recent survey on community attitudes towards violence against women revealed some alarming statistics. 1 in 5 Australians believe that domestic violence is a normal reaction to day-to-day stress, and this perpetuates that dangerous misconception. And shockingly, 1 in 4 Australians believe that if a woman does not leave an abusive partner, well, she's somehow responsible for the ensuing violence. And 2 in 5 Australians would not even know where to go to access the help and services they need if they find themselves in that situation. This is disheartening. It is disheartening to know that there is still this attitude in our society, attitudes that undermine women, that reinforce this rigid gender role, that limit women's personal autonomy, and that normalize sexism and deny that gender inequality is even a problem. Now, what does this point to? It points to the need, in my mind, for urgent and comprehensive education programs that promote healthy relationships, consent, and gender equality from an early age. And we also have to advocate and support organizations that provide assistance to victims of domestic violence and ensure that those in need can have a space, a safe space to turn to, and can find the support and resources needed for them to free themselves of this cycle of violence. There is a role for all of us in this. We must challenge these toxic beliefs that perpetuate these acts and work towards fostering a culture of respect, responsibility, empathy, and equality. We can and we must add our voice and actions to the call. Now, as an organization, the Centre for Social Impact has been working in this space for a number of years, helping to co-design, to research, and to evaluate FDV programs with partner organizations, including Zonta House, the Salvation Army, DVassist, Centre Care St. John Ambulance, and Bridging the Gap. And we're delighted to welcome here some of the representatives of these organizations who will share some of the work that they do with us. So thank you all, and I'd like to, I'm not going to introduce them, but they are here. We've got, well, I will introduce Carole Donaldson, and the head of clinical education at St. John's. Carole, welcome. We have Meg Abercromby. Meg, the senior national specialist at the Salvation Army. Kelda Oppermann, the CEO of Zonta House Refuge Association. Linda Holborow, the Plan Project Coordinator with Bridging the Gap. And last but not least, Kate Ferguson, Dr. Katherine Ferguson, the board member for DVassist. And the way we will proceed is we will give 5 minutes to each panelist to share their thoughts in a very loose and free way with the audience, and then we will open it up to a broader conversation. So I'm wondering, do we need a 5-minute like little bell, a little ding to tell us when we're there? Yes, you may get so enthusiastic. Half an hour later.
Just raise my hand.
Okay, all right.
So,
So perhaps we could start with you, Kelda.
Right. No hands up. I've been given permission to talk loose and free, which is a bit dangerous towards the end of the year. But thank you very much for having me and to be amongst some amazing organisations. So I'm Kelda Oppermann. I've been working at the Zonta House for nearly 11 years. We, for those of you that don't know, we're I would call us small, but technically we're a medium-sized organisation based in the Perth metro area. We are a family domestic violence specialist service. We've been operating for nearly 40 years, and over that time, we started as a refuge organisation, so a safe refuge for women without children in their care. And it was at the time that it was family refuges, but it was seen by a Zonta member that there were no refuges for women without children. And so it was started by the Zonta Club and Zonta International all that time ago. About 12 years ago, we had, we were accommodating, we had 19 properties and one refuge service, but obviously it was just providing accommodation services and what we knew and what we could see was that just providing safe accommodation wasn't sufficient. And so we have spent a lot of time in looking at what we do and looking at opportunities to improve and build our services to provide some wraparound holistic programs, because what we found out and the research that we did, but also most importantly is talking to the women, was that there was huge gaps in support and healing services. And so we've been fortunate to build up a suite of programs really focused on women's healing and what services they need. So we currently have about 65 staff. We work across the Perth metro area. We've got 2 24/7 refuges. We've got supported transitional accommodation. We have wellness programs focused on the women's wellbeing and recovery after the abuse and violence, and we've got outreach programs for women who are still either living with the perpetrator of violence and abuse and or who've left the accommodation but doesn't need refuge or can't get into refuge. We have programs that work with women in prison and exiting prison in recognition of the high number of women in the adult justice system who've experienced family and domestic violence. And we have employment and education programs as well. So what we and just coming back to our partnership with CSI is we've collected a lot of data. We had looking at and what was important to us was because the women that were accessing our service were so different. We've got women who are 18, we've got women in their 80s, we've got women from all different cultural backgrounds. Is what does success look like for us? And for us, it's not about if they get a job or if they if they're studying or if they get their own house. Because the women are so different, what we really looked at was if a woman is well, no matter what she is, her background, no matter where she's from, if a woman is well, she's more likely to succeed in whatever she wants to do. That's kind of the basis of who we are and the services that we provide. So really focused on each individual and their own personal circumstances, and making sure that we're providing support to her, no matter what is going on in her life. So providing, really focused, person-focused, response-based practice support, recognising the woman's strengths as well, because until we actually recognise what is actually taken away from her rather than what is done to her, we won't actually understand all of the impacts of the family and domestic violence on a person. And so providing the actual services and support to victim survivors, but then also recognising a couple of years ago was that that's not enough, because we're just constantly Band-Aid approach. So we, and there wasn't many prevention services over here in Western Australia. So we started up an empowerment through education program, so looking at improving responses in workplaces, improving service responses as well, because of the continuous harm that women were experiencing from systems and from services, not just the abuse that she'd actually experienced from the perpetrator, but then the systems abuse and the ongoing hurdles and onus on her. We provide. Okay. Yeah, so just
We will explore some of those items a little further.
Appreciate it. Thank you.
No, thank you. Thank you.
Thank you. Hi, everyone. My name is Meg Abercromby. I'm the state project lead for our the Salvation Army WA Family Violence stream, but I also sit on our national specialist team. So I'm here representing Salvation Army nationally. Many of you probably have heard of Salvation Army, the large not-for-profit organisation working across multiple different areas, alcohol and other drugs, family violence, homelessness and youth services. I'm sitting here today on behalf of our family violence stream. We, I guess, work across the care continuum or the prevention continuum, from primary prevention responses all the way through to response and recovery, so like crisis accommodation. And so we have a large focus on, I guess, multiple different areas of family and domestic violence. We're spanning into primary prevention, similar to Zonta, as definitely a need for the sector and something that we see as a growing area. But we're also definitely still seeing at that response and the recovery end need for further support and further funding from state and federal government. So yeah, I'll be interested to carry on with conversations today around men's behaviour change programs as well, and for individuals using violence. That's another space nationally that we work quite closely in. So yeah, that's a bit about us. Much quicker than 5 minutes, sorry.
Well, thank you. Mine will probably be quicker than 5 minutes.
Good. Got a few notes here. So thank you first of all for inviting me to speak today. So I wanted to provide you with a bit of an overview of St John WA. When I say I work for St John, a lot of people say, so you work for St John of God? No, St John of God is obviously a hospital provider. So St John WA is a not-for-profit organisation, which is very unusual for an ambulance service provider. So it's unique across the whole of Australia and New Zealand. But we not only provide emergency ambulance for the state, but also medical health services in the form of urgent care centres, and obviously our first aid training, and we do mental health first aid training as well. So just to let you know, within the metropolitan area where we're all gathering today, an emergency ambulance will often be staffed by career personnel, where at least one of the teams are qualified and registered paramedic, whereas within our regional and remote areas, the crew may both be volunteers. So they're not registered healthcare professionals, but they will have received internal training from us at St John. Small country towns, they'll often know the individuals that they will respond to. So in 2022, St John responded to over 288,000 emergency calls. Of these, 6,000 were classified as trauma in the home. So we cannot at the moment define trauma in the home to be anything concerned with family and domestic violence. So we're looking into those processes, and we're working on a new functionality that will flag that within what we call our computer-aided dispatch system. So late in 2022, St John's secured a 2.1 million grant from Advanced Communities, and we were talking about that earlier, to develop education within the sector leaders to deliver this education to 3,000 of our frontline officers. That will enable them to recognise and respond appropriately to victims of family and domestic violence. We commenced the education programme in October this year, and we've delivered it to 140 of what we call our State Operations Centre 000 call takers. So these are often the first point of contact with any victim of FDV. Education will continue next year when we deliver this comprehensive programme to our emergency crews, both in the metropolitan and regional areas of WA. And then we'll transition to BAU, or business as usual, where we'll look at a programme that's delivered annually around continual professional development. So it's on our agenda every year. We've collaborated with sector leaders Stopping Family Violence to develop our programme that will suit the whole workforce, and particularly those, as we said, in the regional towns who may often either be victims themselves or know the victims they are responding to. The content explores the various forms of FDV and develops our St John team members to understand the impacts of FDV, perpetrator patterns, partnering with victim survivors, and the use of FD-informed language, listening with empathy and without judgment, and being aware of the impact words and language can have. We often only get a small window of opportunity face to face, and that could be as short as 30 minutes with these victims. We often call them patients. We've turned our language around to victims. Most importantly, the education emphasises keeping victims safe by understanding the importance of being guided by the victim survivor and their needs. St John emergency medical personnel frequently encounter incidents of family and domestic violence, unfortunately, in the course of their work, and tragically that includes homicide due to FDV. Such cases take a significant impact and emotional toll on our frontline team members. There are also increasing instances when patients or victim survivors refuse transportation to further healthcare facilities and remain in ongoing vulnerable environments. These situations are complex, and the presence of WA police may impact the situation, making it more dangerous for the victim survivor. So the education programme will enable our attending crews to partner with the victim survivors to ascertain if the police presence would actually exacerbate the situation. We look forward to partnering with the health authorities to ensure a safe handover of our patients who are victims of FDV and facilitate continuity of care through the healthcare systems. We're developing through our electronic patient record, so that's the handover that we give to the department, the functionality for our crew members to flag any suspected FDV that may assist ongoing care within the healthcare facility. We've also developed a similar functionality with the State Operations Centre, where the 000 call takers will flag a suspected case of FDV and transmit that to the responding crew, so they already have that forefront of their mind as they approach this particular individual. We're very appreciative of the grant that's been awarded to St John that will enable us to provide this comprehensive education to our team members that facilitates a safe response to victims of FDV and the ability to convey information to appropriate healthcare providers for ongoing care while capturing data to inform further research and education, and hopefully a systems approach to the provision of care and services for victims of violence. Did I do it in 5 minutes?
Yeah, hi. I haven't written anything down, so just going off the cuff here. So I'm representing an organisation called DVassist, which is pretty small, and maybe some of you haven't heard it at all. DVassist was, I've been on the board there for coming up to about 3 years, and it was founded by an author in down south who managed to get $2.3 million in federal funding to start an organisation specifically catered for responding to victims of family and domestic violence in rural and regional and remote WA. I came on board just after that grant was given, and just a bit about my background. So I'm a senior forensic medical practitioner. I work at the Sexual Assault Resource Centre at SARC at King Eddie. And I also have a background in emergency medicine at Charlie's as well. Some St. John's Ambulance has been working with Charlie's and the people that I'm also working with. And in my line of work at SARC, we cover the state for our own calls. So anyone who's been sexually assaulted calls us. And so I speak to everyone across the state. And it became very apparent quite quickly I've been doing it for 10 years, that there was very little services for victims of sexual violence, but obviously DVassist is specifically on failing domestic violence, for counselling services. And it's extremely difficult accessing a GP to get a mental health care plan to then go and see a counsellor when your GP waitlist is 3 months long. You have miles and miles to travel into town. People in town actually know who you are. And so we were trying to use technology to help facilitate ease of access to counselling services for victims of failing domestic violence. I'm very passionate about this as well, because apart from doing the on-call stuff through my work, we also do post-mortem examinations from sexual violence. And anecdotally, I can say that some of the post-mortem examinations that I have done in the context of family domestic violence, those women that are flown down here from the regions have experienced a level of violence I have never, ever thought I would encounter. So we can say it's difficult because obviously somebody's dead in a metropolitan area or a rural area, but there is a difference, I think, in what these women have experienced prior to death. So I'm trying to really work in, apart from sexual violence and failing domestic violence, pretty much in anything that I can do. And that's why I'm on the board of DVassist. So we're so small that maybe some of you haven't heard about us because we nearly lost funding. And we were partnering with the Centre for Social Impact to review that. After the federal funding was granted, there was lots of different kind of KPIs that we had to meet. We had to build a map, all this other stuff that they specifically wanted, a directory of all the services in the regions. But as a clinician, we kind of, anyone who was one of the counsellors who was working in the service was pretty clear that our main focus was not to duplicate anything that's currently on the ground, was really just to help support those services that were already there and help support mainly women having access to our service by telephone. And that would be in the recovery space, which is really where we're really focusing. So I'm a board member, and our CEO can't be here today because she has another job because we ran out of money, and she hasn't accounted for any of her salary. So she's been working completely free for our organization for the last year and a bit, and we've managed to but I think we're really getting there, and I think she is so passionate, just like myself. That's Ella Aliani, about providing these services to patients, to women, because when there was a possibility of us potentially closing our phone services, Ella was taking calls from women saying, I have nowhere to go, I have no one to speak to, I can't get into a wait list, please help me. And she received a few of those phone calls, and that's just like, she's now just doing it in her own time. So I've got a lot of different kind of hats on, and in terms of today, that's pretty much all I have to say about DVassist right now. Yeah.
Thank you. Linda.
Thank you for thank you. I'm from Bridging the Gap. I'm the coordinator of the PAN project, and that eventuated because Lot US had funded us about $728,000 to support parents that were going through domestic violence, employment, financial difficulties, mental health, and homelessness. So the program was evaluated by Marina and her team, and it proved to be really, really successful program. So BTG decided to fund me for another year to do the program, which I was really excited about. So I'm a mentoring coach, and I'm actually down on the ground with these women. So I'd just like to say, if you just walked out your house right now and just looked around, it looked like a tornado or a cyclone hit or an earthquake, and you're standing there in just rubble and the dust is there and you don't know which way to go. And you're looking around, you've got no home, you're coming out of this violence. Makes me emotional. That you need your community. You need your community. So the plan project, so what I do is we have a holistic program which goes through housing, finance, employment, mental health, lawyers, study, so anything they want. So we put together then a personal life plan, and then they set their goals into what they're looking for and what they want to achieve. So a lot of them have come to the program, they're still in domestic violence at home, and a lot of them have come from refuges that refer to the program. I think the longest I've had now working with me is for 2 years. So they have a mentoring coach that I work with, an hour appointment every week until they reach their goals, that they feel like they can get back on their feet. They've got shelter, they've got the BROs, they've gone to courts, they've got their driver's license, IDs that were missing, employment, resume, anything that they need, it's their plan. So I walk alongside them until we achieve these things. And as we're achieving them, their self-esteem and their confidence and their worthiness and their identity is found. And they're empowered, and we've had amazing results and some really good outcomes that Marina has actually interviewed, some of, or quite a few at the time. So over the 2 years, we've had 174 referrals, and I've worked with 134 of these parents. It's changed their children's lives, and some of the support can be just something like get their driver's license or pay for driving lessons or get their car registered again so they can just, you know, keep going. Employment, but it is actually whatever the healing, the self-development healing is the most powerful, because once they have that empowerment and that self-esteem and confidence to know that they're a victim of something, you know, and they realise that and they start working on themselves. And that's when I teach them then to that ship that they're in and they're bouncing around. I teach them how to get that steering wheel, which is the steering wheel of your life, and you drive it in the direction you want to go and you be empowered. So, yeah, unfortunately, the program's going to finish in June next year unless we get funding to continue this awesome, amazing program that we can get funded for another year. And we have proven it.
Some of the things that were just spoken about just now, how harrowing the need is, but also the impact of FDV on the individual, how they, from conversations that we had, how it breaks the person. And often what we found was that there was this loss of being, a loss of identity, and a loss of thinking, well, I'm not even worth being a member of society. So programs that are able to, little by little, through focusing on the well-being, can build the person up again to just feel like they can have a life, are really important. So that's, I think we've heard from our panelists that, you know, there is desperate need, and desperate need not only for those women, but the children, the lives around them. And that's one of the things that we had heard, that when the mother is whole or on the road to recovery, the children are then stable, and it has this generation impact. Some amazing work being done, some really sad news also about what we're seeing out there. But let's focus on that a little bit now. Let's explore what is happening. What is this need in the community? What is driving this need? What is it that we're seeing? What has changed in recent years?
I think recently, in the last, I'd say coming up to a year, but really the housing crisis has really has been pushing women specifically and their children into unsafe living situations. They are finding accommodation on Gumtree or through a friend of a friend of a friend. And women are sexually assaulted in those areas. And I think apart from that crisis that happened and the complete lack of accommodation from prior to anything happening, when patients do present to the emergency department, there is nowhere for them to be referred to. Our social workers in the emergency departments are struggling so much to try and get patients, even patients with children, into accommodation. And the other thing I think that has recently changed is the second wave of COVID, which has been happening. The government is now, we're not in a crisis, a state of crisis. And so there is no refuge beds specifically set aside for women who are COVID positive. So if you are COVID positive and if you also have children, you turn up to hospital and there's nowhere to go, you're essentially just discharged, which is, personally, this was happening to me a few weeks ago. I was very upset and ended up in tears at the end of the day trying to sort this out. Wasn't really sure what to do with that, but I think I can say the housing crisis is affecting families and women and children massively right now. Yeah.
And what else? What other drivers are there that you see?
I think when we're talking about family and domestic violence, we're talking about the need. It's up here, and we're just constantly, for years and years, we've been doing drops in the ocean in regards to being able to meet that need, whether it's a crisis response, whether it's intervention, and certainly not around prevention. What we've seen, even if it is, even though we're grateful for funding, that we're grateful for the 2 million, we're grateful for 10 million, it's still not meeting the need. We're not being able to actually meet the need of people who are crying out for help or who need help. We're not being able to actually address the gender drivers that continuously enable and foster the environment and the social environment that has allowed or enables family domestic violence to happen. It's just drops in the ocean, and until we actually invest adequately, so that services that can continue, services that we know that work, services we know we've got the evidence for, until we actually invest adequately to meet the need, we're just continuously going to be in this cycle. We might be making a difference, which is so important. We need to keep women and children safe right now, but we also need to actually invest and in prevention and address the gender drivers that are enabling family and domestic violence to continue. And that is, media has a role to play, education, universities, schools. It's so much. The complexity of it and the work that needs to be done is significant to actually shift the future for all of us.
And one point I wanted to pick up on what you had said, Carole, about what St. John's was able to do. I mean, being medical, I'm like data.
Mm-hmm.
But we need the data in order to say what is actually happening. We know kind of roughly from these surveys, personal safety surveys, what's happening. But in terms of when patients, victims actually present to hospital, being able to actually go back and track, well, how many of these presentations were related to family and domestic violence? It's very, very difficult. I'm on this, like another working group I was saying to Carole before with St. John of Goa, with Sir Charles Gardner Hospital in the emergency department there with E. Foreman, who's met with you before, and looking at trying to capture the data. When you try, there was only like minimal numbers on thousands and thousands of patients that come through that emergency department, and no one's coding it, no one's capturing it. And I think we need to kind of change the conversation from being a Department of Communities social work issue. I'm very strong in changing it to everyone having ownership of it, specifically in the hospital system, because we know that like the crisis point, they're going to present to the emergency department. And we need to know how many of these patients are presenting, what's the follow-up in terms of like long-term complications from traumatic brain injuries, from non-fatal strangulation or direct blunt force trauma to the head, these kind of things. So I think it's amazing what St. John's is doing in terms of being able to capture that data from what you guys can do, obviously in a safe, respectful way, which wouldn't put anyone at risk in terms of data sharing with anything. But yeah, I feel like being able to change that the conversation from Department of Communities, just them, trying to get public health physicians, trying to get our emergency department staff, everyone on board, and it's everyone's job to do a risk assessment and document injuries to help these women if they do potentially want to go to court and they have good injury documentation. I'm obviously thinking forensic now, in order to be able to help hold their perpetrators accountable in court.
I think it's huge systemic flaws across the board. You know, we've spoken about the medical industry, which I think we saw, you know, a huge fallout from COVID and FDV kind of exacerbating some of the tensions that were, I guess, already existing in that environment. But we're also seeing, I guess, issues across, you know, legal sector, you know, not just medical, but social work sector as well. And really all of these, I guess, systems have a part to play in supporting. And I think particularly COVID, the cost of living crisis, and the housing crisis has kind of almost exacerbated and brought a bit of this to a head. So I think we're really seeing that kind of need for crisis response, but we're forgetting that like social inequality is the context in which this issue sits, and that we really need more investment and serious investment from government around, you know, this issue. We saw in Victoria the Royal Commission make a big difference in I guess the systemic approach to family and domestic violence, and I think we need that nationally as well.
There's also this big cultural piece, and I'm cultural as in the societal acceptance. And let's turn a bit around to the points of intervention. How can we, at what point can we start to make inroads so that we're not responding, but we're actually shifting, we're changing the system, we're changing society. So it's just not cool to do that. It's just not done to be violent. And violent can be the words that are used, obviously, as well as the physical violence.
Yeah, I think what I found is that, you know, out of the 134 that I've worked with, they see domestic violence as, but he didn't hit me. They're still saying that. But socially isolated, they're home, not allowed to study, non-English person that I've had wants to learn English, not allowed to go out, not allowed to learn English, stay at home, do this, making calls if they're out, how much have you spent at the shopping centre? And they say, but he didn't hit me. And they're just disempowered, you know, and they're brokenhearted, and there's confidence. We'll do the scale. We do a self-esteem scale to see what's their scale when they come in. And my role is to help you increase that. And I'm sort of go for you. And they go, yeah, right. Well, let's see this one on. I'm really, really in a bad way. And I've got proven evidence that what we're doing and building that self-esteem and confidence, but teaching them domestic violence is not just physical. Mm-hmm. So if we get back to education, women, children, I'm not sure what age you would start. It's not acceptable to grab your phone and check your texts and, you know, text you 30 times a day. They need to know this, you know, they really do need to learn it.
I think it has to start in primary schools, but looking at that respectful, equal partnership. Yeah. Whether you identify as being male, female, or non-binary, and it's about those relationships together and what you can achieve in that respectful and equal relationship. We were just talking earlier about the sexualisation of females and how young boys actually see pornography as being the normal relationship within, you know, a sexual relationship. So I think it has to start.
Yeah, we need to start back before.
Yeah.
It really has changed in terms of the sexual violence that we're seeing in the last 5 years, I reckon. there's a particular kind of early 20s, a little bit kind of mid-20s, that particular demographic of girls who are coming in. The language that is used towards them is shocking, extremely derogatory. Pretty much everyone is choked. And I'll go into all the others. I don't need to go into that now, but it's very extremely violent sexual violence which is happening, and it's very, very much porn flavored. Yeah, it's completely. And when are we going to talk to kids? When are we going to kind of change the conversation around porn? And people think of porn as, you know, what they kind of were aware of, like little magazines or something. Like, it's not like that. It's completely changed now, and it's changing these kids, these children's brains to be turned on by this extremely violent, aggressive behavior. So I think something needs in primary school.
Back to addressing the drivers of gender inequality and family and domestic violence. If we turn to I guess our watch as a kind of peak body in preventing violence against women, you know, they talk about the condoning of violence against women being an issue that we very much need to challenge. I guess limiting women's decision making in public and private life. So very much that like systemic influence that I guess patriarchal structures have on you know, society at large. You know, we think about rigid gender stereotypes and the negative impact that that has not only for women but men as well. Men's spaces are not safe for men, and I think we look at men as, you know, the privileged individuals within our society, but their spaces also aren't safe for them either. And also, yeah, the normalization of aggression and dominance and what masculinity means. I think we really need a holistic approach to addressing all of those things in order to truly make social change. And we have programs, a program specifically within the workplace setting, focusing on, I guess, developing respectful relationships and normalizing conversations to ensure that workplaces aren't, I guess, reinforcing some of the problematic attitudes and beliefs that we see. So I think we really need to think about those kind of key settings as practitioners and as individuals in, you know, what can workplaces play as changing social norms? What can schools play? You know, what part can schools play? All of those kind of things in order to really have a holistic response to this issue.
And the role of media to push this conversation. A few years back, there were those ads on the telly about the girl being pushed by the boy. Oh, he does that because he likes you. And then really telling, you know, the message was, you've got to stop this. It's not on. And it sort of has gone quiet. But I think that the role of media and that big tier conversation sponsored by government is really important in this. And maybe that's where you start to have these uncomfortable conversations around pornography. Now, please.
Just because I think it comes down to it's a social issue, and we actually need to change our frame that this is a public health issue and shift away from it being, you know, family and domestic violence. You know, this is a public health issue that we're facing, and you know, the only way that we're actually going to get the investment from government or from workplaces or philanthropy is for people to care. And it's for people, it's for everyone. You know, we say, well, it's everyone's responsibility. That is what it's going to take. We need everyone to care. We need everyone to prioritise this in their workplaces, in their communities, in whatever role that you play as an individual, to push this and do what you can within your role in your life, in this life. That is the only way that we're actually going to push government, push workplaces, push the public to actually make the investment that we're actually going to be able to achieve all of these things.
I'm aware that we've got 10 minutes, and I really would love to open it out to our online partners. Hello.
So we have a question online. I guess we've answered one part of the question already, but there's another part here around men's behavior change programs, and I think the person that asked the question would love to hear more about what's up there.
Yeah, I'm happy to start. I guess Salvation Army had a few different, I guess, fingers in this pie. We work nationally in this kind of space and have men's behaviour change programs primarily in Victoria at the moment that have been very successful. But I think it extends beyond just men's behaviour change programs. I think we really need to look at the prevention and early intervention, particularly around, you know, partnership with police and what role that can play in early intervention, and I guess identifying at-risk families so that we can better provide support to those. I probably can't talk too much to the men's behaviour change programs myself because I don't really work in that space, but we do have programs nationally, and if you would like some more information on what's available, I'm more than happy to seek some information and have it sent around for you.
We could share that.
Yeah, absolutely.
There is, so in WA, and I apologise if I'm going to miss anything out, but so community run breathing space, which is a residential behaviour change program. I know that Anglicare and Centre Care also have counselling group programs, and there are programs run in the justice system as well. But we need to scale that up.
Yeah.
So it's a drop in the ocean of what's actually required, and we need it to be. There's the mandatory programs, but there's also not enough volunteer programs as well. So for men who want to change their behaviour or perpetrators, there's not enough volunteer-based programs that people can choose to access support.
And again, that behavior change is not just, you know, the men, it's women as well. That's something that is, I know in my life, I've seen that there's certain expectations that how women are and how men are. And that's something that broader discourse and conversation has to address.
Yeah, there needs to be specialised support for everyone to be able to access.
I think what is a healthy relationship? What's a healthy relationship in a family with children? And when it's a cycle of violence, their normal is, doesn't that happen to your house? Like with yelling and screaming and fighting, and you don't talk about it because it's normal. And then you go up and go, hang on, there's all this is violence. You go, really? Stop sitting with that, years ago. So I think it's changing. What is a healthy relationship? What is a healthy family? So if you're noticing these red flags, which the refuge always, has a look at, that say, hey, this doesn't tick the box of being really healthy. For male and female, it doesn't matter, just as people in a relationship. That respect, and we don't have that.
That's one question. Do we have any questions from the broader audience?
Hi, it's for Carole. I was just wondering, I don't know if I missed it or not, but with the service that's rural region, when you said they're volunteers, is there like a screening tool for ABI or traumatic brain injury to the, when you come in contact with the patient, and you transport them?
Such a good question.
I've noticed in other states they do have the screening. I was just
Or traumatic brain injury. There's no screening tool, so they're doing an assessment process.
Yeah.
So whether that TBI, traumatic brain injury, is old or whether it's a new event. Obviously, if it's a new event, we can see that we go via a mechanism of injury. But there is no screening tool for pre-existing, shall we say, traumatic brain injury.
You can do immediate like concussion screening, which Charlie's is, getting into. We've looked at Charlie's, the documentation that's happening for family domestic violence victims who are coming in. We've kind of changed it to be more like a trauma sheet that doctors are more used to doing. And on that is concussion screening. But in terms of long-term traumatic brain injury, acquired brain injury as a result of blunt force trauma or non-fatal strangulation, et cetera, you're more looking at kind of long-term follow-up in terms of like MRI changes or MOCA, like in Montreal cognition assessment scores if they're changing. It's very difficult, I think, for paramedics as like a one-on-one first time meeting somebody to actually assess, unless it's very obviously mechanism of injury at that time. Long-term impact of that is going to be quite hard for it. Them at that time, I think.
Yeah, I think the other thing to consider is that if it's a dangerous situation, so if they're called to a suspected 15-lead case and the environment is dangerous, they won't enter that environment without a police escort.
Yeah.
So that's a consideration as well, is their safety prior to going into that area.
And just on that, so a lot of them, obviously, volunteers would be Aboriginal region.
Yeah.
And rural, so
Yeah.
they're in high Aboriginal population.
Yes. Yeah.
Are they aware or do they get training of the difference of level of acceptance that our communities have with violence? Because I say that is from my own experience on Torres Strait Island, but growing up in many Aboriginal communities and the level of acceptance that we have to non-Aboriginal people really needs to come, sort of into a meeting. But I'm just wondering with your volunteers, because they are put in that situation and there is heightened emotions and, everyone's in that space. Do they receive the appropriate training to keep them safe?
So they receive training in danger in particular, so that it won't be differentiated what that danger is.
Yeah.
However, this education on domestic violence, we're particularly looking at First Nations people. And what we're doing in the volunteer space is we're actually getting the culturally appropriate education.
Yeah.
Because each region is different, as you know. Yeah. So we're looking for advocates within those regions to actually go out with the crews so that they are aware of the mobs in that area, etc., the language, all of those things. Yeah, thank you. Yes.
I was really pleased to hear you bring about the emotional and psychological aspect, because this is part of domestic violence, but it's one of those where there's no marks except in the brain, or to such an extent that the lady in these cases will take her life. So there's that aspect that needs to be brought out as well. So much is brought about on the harm, physical harm that is being done, but you don't hear so much of the psychological. And if a woman is in this psychological situation, at some time she might lash out and then she is blamed, but then it is not her fault. A second question I'd like to ask is, or suggest, you're talking about the media and advertising. That's only if the people see it at that time, and have they got time to put it down in their text. But where can the supermarkets come in with advertising? You see them in the doctor's surgeries, but then people are watching and have seen in the neighbourhood. In a supermarket, if you have your leaflets, anyone can go and assist in that way, and it almost becomes neutral that they aren't seen as to who they are, where they come from. But it gives them time to put something in their text or be able to contact, etc. And my last query is it the overall number that you're giving us, such as 1 in 5, or have you been able to put it into ethnic distributions, which is what we have in Australia? We're talking about Western Australia as well. How much more would it be in some of these ethnic communities than it may be in a long-standing Australia?
Lots of questions.
I'll just jump in quickly around the so coercive control. The Victims of Crime Commissioner, so Kathy Breslin, has recently, with the Department of Justice, released a consultation report on coercive control, and in there she's got a list of recommendations. It was only released last week, so I do recommend having a read through that. And part of that is around educating the legal system and the community around what is coercive control, but also how are they suggesting that is potentially legislated, so that it is seen as a crime as well. I've forgotten all your other
I think
questions.
as well, in terms of, you were talking about if a victim, if a woman had been subjected to coercive control for a long term and she lashes out, I think there has been some education programs that have been happening for like the police and justice system in terms of recognizing the true perpetrator of violence in that relationship. So there has been a bit of a kind of a cultural shift in that kind of those police who are called out. And then I'm just thinking, this isn't necessarily one of your questions, but did just prompt me to think about legislative reform and coercive control, which has happened. I think there is a scope in terms of addressing this for victims of domestic violence to for ease of prosecution and a legislative reform in terms of, like, say in Scotland, there has been a review of all the legislation and a single charge of domestic abuse. That's what they call it there. So instead of trying to charge individual acts, coercive control, non-fatal strangulation on the second, one force head injury in December, all these multiple things, which currently people have to go to court and prove the individual things that has happened to them. It's more of a broad stroke, kind of see the wood for the trees kind of thing. When you look at everything all together, would you say balance of probability is that this was domestic abuse? So I think there is room for that, and I think that that's more of an appropriate response from the justice system and much more victim friendly. Totally off topic from your questions because I can't remember anything else.
If you're interested in that, something to look up is retaliatory violence and the role that retaliatory violence plays within family and domestic violence. That's kind of, I guess, what you're speaking to in that sometimes women retaliate, but really, I guess they can be looked at as victim survivors in their own right. So, yeah, there's lots of research into that.
You talked about social marketing as well. I think we touched on that. So I think if we look at it from a public health epidemic almost, then social marketing would fit into that. The 16 Days of WA have certainly brought it to the forefront, but it needs to be at the forefront 216 5 days. Yeah, absolutely.
And around the issue that you said, the scars of violence and how they are unseen. Actually, there is research, medical research, that says living in that heightened fear and violence changes the morphology of the brain. It actually changes.
I understand that. What I'm saying is there's no markings here.
Yes.
Which is what people would
Yeah.
get, such as the police get job ambulance. Yeah. But there's definitely a change here and a personality change.
Yeah.
And towards the children, family, or her family.
I think it's really appropriate. We were discussing this earlier today about the education that we're going to provide. We'll actually put a lens on those psychological mental health issues that perhaps our crews had responded to before and just thought it's a mental health issue, but now we'll look at it from an SDV. Yeah, much more.
And it goes on for years and years until you look at the healing and that self-esteem, confidence and self-worth of who you are. I've had quite a lot of my clients self-harm. I'm like, you know, you've got children, you're out of the violence, but emotionally, just what you're saying, they're still not dealing with it. It's the healing that's going to happen. They'll go on for years.
And I think that use of drug and alcohol and as a coping mechanism for those traumas that people have lived through, and recognizing that when patients too are assessed and by centre of ambulance or whatever, that might be a mechanism for what they have experienced, for them to cope with that in a short-term kind of plan.
You got a question? No? I think we're going to wrap it up. Thank you all very much for this conversation. I think, you know, a lot of really hard-hitting topics or things were said, but there's a lot of positive things emerging as well that shows that hopefully we are trekking in the right direction. And my takeaway is that really this is for all of us to be champions about. And well, thank you all very much for coming.
Thank you.